I think it's important to understand that glaucoma is a common disease, and it's actually a group of diseases. And it's a group of diseases that damage the optic nerve. So what's common with glaucoma is optic nerve damage. Now, it's quite a common disease, and it's estimated that about 1 in 480,000 people in England alone have chronic open-angle type of glaucoma. And it's certainly true that as we get older, as we age, the incidence increases. And again, it's been estimated that about 2% or 1 in 50 people over the age of 40 have glaucoma. And as the population ages, over 10% or 1 in 10 people over the age of 75 have glaucoma. And so age is an important risk factor for glaucoma. But to the question of what is happening in the eye, it's a progressive optic nerve damage. Now, the optic nerve sends the signals from the retinal ganglion cells. So these are a layer of cells within the retina that form the optic nerve and then send the signals from the optic nerve to the visual cortex at the back of the brain. And with glaucoma, there is progressive damage to the retinal ganglion cells, and that causes progressive vision loss. And progressive vision loss is the hallmark of glaucoma damage. There are many different types of glaucoma, and it's classified in different ways. The usual classification is divided into what we call open-angle glaucoma and what we call angle closure glaucoma. What this refers to is the drainage angle. If you think about the eye like a bathtub, you have a tap pouring water into the eye, and you have a plug hole draining water out of the eye. With the open angle type of glaucoma, the plug hole is open, but the pressure damage continues to damage the optic nerve. With angle closure glaucoma, the channels which drain fluid out of the eye are blocked. So the fluid within the eye, the aqueous humor, can't drain out of the eye effectively, and therefore there's a buildup of eye pressure. We can further classify glaucoma into what we call primary or secondary glaucoma. And that means that for primary glaucoma, there is no other underlying reason for it to have happened. It can happen just out of the blue. We have secondary glaucoma, which means that the glaucoma is caused by other mechanisms. And there are many different types of glaucoma, secondary glaucoma. For example, people who might have chronic inflammation in the eye or uveitis can develop secondary glaucoma. People on certain medications, like steroids, for example, can develop glaucoma. There are certain secondary glaucomas that, again, happen for genetic or no other underlying reason, such as glaucomas we call pseudoexfoliation glaucoma or pigmentary glaucoma. So we have the primary and secondary, and then we have whether it's open angle or closed angle. And then we have what we call developmental or congenital glaucoma. This is a much less common type of glaucoma that tends to occur in babies and young children. And this is because there is a developmental problem with the drainage system of the eye. So the fluid that's made inside the eye can't drain out of this underdeveloped drainage system. And the pressure builds up, and that causes the glaucoma in children. So these are the different types of glaucoma that we see commonly in our practice. Very often, and in the most common types of glaucoma, there are no warning signs at all. With open-angle glaucoma, the disease progresses very slowly over a number of months and years, and people will not be aware of the symptoms early on in the course of the disease. With progressive glaucoma, the peripheral vision preferentially gets damaged before any central vision loss. And people will be much less aware of loss of peripheral vision than they would if the central vision was lost first. The other eye may well compensate for vision loss in the more severely affected eye. The brain is very good at compensating and filling in what it thinks should be there. So people are unaware of the progressive nature of the vision loss. And in fact, this is the time to diagnose glaucoma before it causes symptoms, because if glaucoma damages vision, that loss of vision can't be reversed because glaucoma causes irreversible sight loss. Now, if we diagnose it and treat it effectively, there is no reason why people can't maintain their vision lifelong. But if it's not identified and it's not treated adequately and the glaucoma progresses, then a progressive loss of vision happens. Now, in some other types of glaucoma, which are less common than open angle glaucoma, and we're thinking about angle closure, sometimes there are warning symptoms. As I mentioned earlier, angle closure means that the drainage system of the eye can close up, and therefore there is a build-up of the eye pressure. Now, if the drainage system closes up progressively over a long period of time, again, like open angle glaucoma, there may be no warning symptoms at all. However, in certain cases and in certain groups of people, the angle can close very suddenly over a matter of hours. And this can give very severe warning symptoms. People often complain that for a few days or weeks before an acute event, they may notice temporary loss of vision. They may notice halos or rainbows around bright lights. And then suddenly what can happen is that there's a massive buildup of eye pressure. This causes nausea, vomiting, a very red eye, painful eye, sudden loss of vision. And these symptoms are very obvious. And this is a condition called acute angle closure. But fortunately, it's less common than the chronic types of the chronic types of glaucoma that we see generally in our everyday practice. With developmental glaucoma, so this is the glaucoma that occurs in children, again, there are very obvious signs when children have glaucoma. Because of the nature of the tissues that make up a child's eye, which have not yet fully developed, if children develop a raised pressure inside the eye gets progressively larger. And so parents would notice that the eyeballs are getting bigger. Children would also get symptoms of light sensitivity, lots of watering, eye rubbing. Then the front of the eye can start to become cloudy. And so these are very obvious symptoms that we see in children. But in most cases, in the common type of glaucoma that's most common in the UK, there are no early warning symptoms. So there are certain groups of people who are more at risk of glaucoma. So there are particular things that make somebody more likely to develop glaucoma. The most common risk factor for glaucoma is age, because increasing age is probably one of the most significant risk factors for glaucoma. And as I mentioned, in the over 75-year group, almost 1 in 10 people will have glaucoma. Other risk factors are the ethnic background of the patient. So people from an African American background or an Asian background are more prone to develop glaucoma. And in fact, in certain communities, the glaucoma can be much more aggressive and more rapid in its onset and more refractory or difficult to treat. Certainly, somebody who has a positive family history of glaucoma would be more likely to develop glaucoma. So particularly if somebody has a first-degree relative, such as a mother, father, brother, sister, or a child with glaucoma, that person is much more likely to develop glaucoma as well. There are certain other risk factors. So, for example, their refraction, meaning whether somebody is very short-sighted or very long-sighted. So people who are short-sighted are more likely to develop open-angle glaucoma. And people who are long-sighted may be more prone to develop angle closure glaucoma. And there are other risk factors. One I mentioned earlier, medication. So people who need long-term steroid treatment for a number of different conditions are more prone to develop secondary glaucoma. People who have ocular injuries, particularly trauma, chemical injuries, are much more likely to develop glaucoma. And again, one of the more common and more well-known risk factors is the intraocular pressure. So this is the pressure within the eye. Now, intraocular pressure is an interesting subject because in the population, there is a normal range of eye pressure. Normally ranges between about 8 and 21 millimeters of mercury. However, there are many people who have an eye pressure above 21 millimeters of mercury who don't have glaucoma. We call this ocular hypertension. Equally, there are people who have an eye pressure that's within the normal range and who can develop very bad glaucoma. And this we call normal pressure or normal tension glaucoma. So the eye pressure doesn't diagnose glaucoma, but we look at it as a risk factor for glaucoma. So if somebody has a pressure above 21, they are more likely, although it's not inevitable, that they could develop glaucoma. And so people who do have a high pressure or a family history or any of the other risk factors, we advise them to get regular checkups by their local optometrists to identify glaucoma at the earliest stage possible when it's the ideal opportunity to catch it and treat it. And treatment's always easier and more effective in the earliest stages of the disease rather than when it's already at an advanced stage. I think there are 3 strands to diagnosis. As I mentioned, glaucoma is an optic neuropathy, meaning that it's a disease of the optic nerve. So examining the optic nerve is really the most important way to diagnose glaucoma. And that is by a clinical examination, for example, whereby a clinician, a glaucoma specialists examine the optic nerve. And there are very typical signs that can be seen in an optic nerve in somebody who has glaucoma. And there are also imaging devices. So, for example, ocular coherence tomography, or OCT, is an imaging device, which is in very common practice, which images the optic nerve and takes measurements of the retinal nerve fiber layer thickness, which in glaucoma progressively thins. And again, this can be used sometimes in diagnosis, but also more importantly in monitoring the progression of glaucoma. So on the one hand, we've got a clinical assessment and an investigation of the optic nerve, which is the part of the eye that glaucoma affects. The second thing is the level of intraocular pressure. As I mentioned, this is a risk factor for glaucoma. So measuring somebody's pressure at the optometrist, for example, would give an idea whether somebody's more at risk of developing glaucoma. And the third strand to it is measuring visual fields, because glaucoma affects the peripheral vision in the early stages before central vision is affected. So we can do visual field measurements now to assess somebody's peripheral vision. And this again can be used in both diagnosis and monitoring of glaucoma progression. So in diagnosis and in managing glaucoma, we think of these 3 things: intraocular pressure, visual fields, and optic nerve assessment. So in a lot of medical conditions, we subdivide the treatments starting from the less invasive to the most invasive. And obviously the decision depends on a number of factors. which one we try first. Basically, we divide the treatment into medical treatment, which in eye disease generally is eye drops. There are a number of eye medications and combinations of medications used to treat glaucoma. We can then move on to laser, and the most common type of laser would be something called SLT, or selective laser trabeculoplasty. And there's a lot of work going on to see what's the most effective as a primary treatment, whether that be medical treatment or laser treatment. And the final strand is surgical intervention. So, for example, if somebody's not able to tolerate regular eye drops because of allergies, irritation, side effects, and so on, or simply it's very difficult to put eye drops in. And you might imagine that elderly people with joint problems or rheumatoid arthritis and this sort of thing can make eye drop installation very difficult. So if medical treatment's not effective and laser treatment is only temporary or not effective, we can then move on to surgical treatment. Fortunately, a relatively small proportion of people with glaucoma will need surgical treatment. And the surgical treatment traditionally has been with an operation called a trabeculectomy. And this has been around for over 50 years. And obviously over that time has been refined and improved, and the success rates are much better nowadays. And effectively, a trabeculectomy is a way of bypassing the eye's own drainage system by making a new drainage pathway. And so essentially, a fistula or a hole is made in the top part of the eye, so the fluid within the front chamber of the eye can drain through the new hole and into what we call the subconjunctival space. Now, although this is probably still the gold standard operation, this does have risks with it. The new fistula can heal over with scar tissue. If we try and avoid scar tissue buildup by using anti-scarring medicines over the lifetime of that patient, that can cause an increased risk of infection. And the eye can become uncomfortable with symptoms of dryness and grittiness and foreign body sensation. So although it's very effective, it does have still some downsides to the traditional type of operation. Some people favor what we call a tube implant. And so this is a stent. So this is an artificial device which is implanted into the eye. So as the eye pressure increases, there is a way and a new pathway for the aqueous humor to drain out of the eye. And again, this may have a number of complications, such as leaving a foreign material inside the eye. And obviously, we don't like to leave foreign bodies in any part of the body because of the risk of rejection, because of the risk of being a focus for infection. More excitingly, there have been new types of treatment, new types of surgical treatment for glaucoma. For maybe mild or less advanced glaucoma, we've got what we call MIGS procedures. These are minimally invasive glaucoma operations. And there are a number of stents that are minimally invasive and can be used in conjunction with, for example, cataract surgery. What I found particularly helpful is an operation called a trabeculotomy. Now, I deal with a lot of children and young people with glaucoma. And now the primary surgical treatment in children is the trabeculotomy. And over the past 6 or 7 years where we've been doing this new operation, the success rate in the outcomes of children has improved so dramatically that we've now started carrying out this operation in adults. And again, this does seem to have a lot of success and a lot of good outcomes from this, and doesn't have the same complications that the traditional types of operations have. For example, there's less risk of infection. You don't have to use any anti-scarring medicines. There's no foreign material left in the eye at the end of the operation. We're using the patient's own natural drainage system and we're opening up the natural drainage system. So we're restoring the traditional pathway by which aqueous humor drains out of the eye. And so this is very exciting in terms of how we can control glaucoma with trying to have a lower risk of surgical complications.